Right. Good afternoon, everybody. Lovely to see so many who have joined us for this lunchtime webinar. A very big welcome to you all. This dissemination webinar will be focusing on sharing the key findings from the mixed method study, exploring barriers to and facilitators of delivering, implementing and receiving an enhanced smoking cessation service for people living with severe mental illness in the Northeast and Cumbria. So we're delighted to have so many people on the call today. This study was conducted by our colleagues, researchers from Northumbria University, on behalf of the NENC Smokefree NHS Taskforce. So we'll start with some housekeeping. Hopefully my slides work. So the webinar is being recorded and will be uploaded to our K-Hub, Boost and YouTube channels. We would ask that you keep your cameras off, but I think that's already been done, if possible, for the speaking slots, and then we'll enable them hopefully at the Q&A session, which will be at the end. Everyone should have been muted, but if for any reason your microphone comes on, if you're not speaking, please kindly mute it so we don't get any feedback. We will have an opportunity for questions at the end, so there'll be a Q&A. So please post any questions you might have in the chat or in the Q&A function on top of your Teams. And when we're having the discussions, we just ask, please, that people be mindful of colleagues' opinions and experiences. Hopefully this works. It's a bit, yeah. So today's program, I'm going to provide a bit of an overview of the context within NENC, and then we'll hear from two of the lead researchers, Dr. Angela Rodrigues, who is the Associate Professor at Department of Psychology at Northumbria University, and Dr. Lauren Hoult, who's the Senior Research Assistant also at Northumbria University. And we also have on the call Dr. Katie Hayton as well. And then we will go into a Q&A session, and we hope to finish promptly at 1 p.m. So just to provide a bit of context in terms of the Northeast, not Cumbria, our approach has been very much focused around and systematically working alongside multiple partners as part of the cessation landscape, where the smoker is put at the heart of everything that we do. My computer's just frozen for a minute there, so we'll just try and hopefully move things on. And that's really important because that smoker and that person with tobacco dependency needs to be at the heart of services, and especially if they've got significant mental ill health as well. And that support, regardless of where it is, that focus has to be continually on that person. And why is this important? Why is this an important area to consider? Well, smoking remains the #1 driver of health inequalities, accounting for 2 in 3 deaths in long-term smokers, and it's the largest cause of preventable ill health, disability, and death. And particularly for those with severe mental illness, there is a strong evidence of higher smoking rates and the associated harm as a result of that. And we know for a fact that smoking is the most modifiable important risk factor that contributes towards the excess mortality in this group. And within the Northeast and Cumbria, this accounts for between 10 to 20 years gap in life expectancy. And some of the old stats we have around smoking prevalence rates within this cohort of the population puts it at 42%, which is more than 3 times the regional smoking rate. So just over 3 years ago, we were approached by NHS England to be one of the early implementer sites for smoking cessation and SMI. And a decision was made to stress test a primary care model, which was done in 4 areas as denoted on the map by the yellow stars. These areas were Northumberland, were South Tyneside, Middlesbrough and Durham, in particular the Chesterley Street area. And some of the people who've been involved in the pilots are on the call. So thank you for joining. So you hear a bit more about this from both Angela and Lauren. And since then, we've extended the work to now include a community model, which is led by CNTW in one of our mental health trusts in the north of the patch. And they have been doing work in the areas denoted on the map with the red stars, which are Newcastle and the North Tyneside area. And what's emerged from the pilot work has been that idea around that no wrong door approach and ensuring that that support was flexible for the individuals who were provided with the support. And since then, we've had the opportunity to host a number of events over the last year and a half to showcase the work of the pilot sites and get the system thinking about how to adopt and adapt these practices within their own services. And so I'm really delighted that now we're going to have the opportunity to hear from the independent researchers, Angela and Lauren, who have evaluated the early implementer site offer in NENC. So without any further delay, I'm just going to hand over to both of them to go through the key findings.
Thank you, Rachel, for the introduction. If we could move on to the next slide, thank you.
Yes, sorry, I'll just share my slides,
yeah.
Angela.
I thought it was part of the deck, sorry.
You see my slides?
Thank you, Lauren.
Yeah, okay, great.
So yeah, we'll be presenting on the evaluation, as Rachel mentioned, and it was really good that Rachel already done the context of the research, so we can move on to the project and to our findings. So the main aim was to evaluate the enhanced smoking cessation service for people living with severe mental illness, and within the project we had several research activities. The first one was to, where possible, look at the aggregated data for recruitment and also for the smoking cessation outcomes. We also look at the documents from all the pilot sites to identify key content and theoretical underpinnings from related to the enhanced smoking cessation service. And a big portion of the research project was spent exploring service provider and service users' perspectives on the acceptability of the smoking cessation service. We also, from that, created some recommendations to optimize the service. Next slide, Lauren.
Yep.
Over to you.
Yeah, thank you. So I'm just going to expand on the 3 different work projects that Angela has summarised there. So as she said, the first work project that we looked at was looking at aggregated data across the 4 pilot sites in terms of recruitment and outcome data. So what we did do is we reported the raw figures, and so the total figures in terms of the number of service users referred, seen by the service, who set a quit plan and who reported a quit at 28 days. So we didn't actually analyse this data any further due to missing data in places and some differences with the way in which data was reported. For example, pilot site B reported the number of times a service user had been seen rather than recording only the first instance. So we just reported the raw figures, but generally what we can see if we look at pilot site A and B that have full complete data where we can make some comparisons, pilot site B saw a larger number of referrals, but when we look at things like the number of, or the percentage, sorry, of service users setting a quit plan or reporting a quit at 28 days, we can see that around 80 to 85% of those who had been seen by the service had set a quit plan, and around 45 to 50% of those who had set a quit plan reported a quit. So the rates are quite similar between the two, where we do have full data available. In terms of the second work project, we collected documents from each of the 4 pilot sites and coded them for behaviour change techniques. So before I discuss that, we'll just talk about some of the characteristics between the 4 sites. So generally the characteristics were quite similar between sites, and these characteristics have been confirmed by people from the sites as well. So referrals were done through annual health checks and sometimes through GPs, or for the majority of pilot sites through GP services. Pilot site B had a specific physical health hub which they used. There were also methods such as self-referrals and using voluntary, community and social enterprise sectors as well. Three pilot sites had specialist stop smoking services, and 1 had used voluntary, community and social enterprise. And there were various modes and settings of delivering the service, such as face-to-face, virtual or home delivery. And the type of support that was available was very similar across the 4 pilot sites, in line with the enhanced approach. For example, enhanced behavioural support, the provision of e-cigarettes, NRT, but some services or sites, did additional things like providing CO verification and utilising vouchers, whether that be to incentivise people to take part or to use to spend on e-cigarettes and so on. So in terms of the documents that we received 55 documents in total, and this is including documents from all 4 pilot sites, but also from some of the overarching documents in terms of the NCSCT training and the overall tobacco dependency service. And these documents related to any documents and presentations and so on related to training, governance and policy, implementation, referrals, marketing and service user resources such as leaflets and so on. And what we looked at was we coded these documents looking for behaviour change techniques, and we did this in 2 ways. So the first one was looking for behaviour change techniques that helped service users to engage in the service. And we also coded separately for behaviour change techniques that would help facilitate service providers actually implementing and delivering the service. So we identified a lot of behaviour change techniques, but I'm just going to summarise some of the main ones that we found here. So for service users, the main behaviour change techniques that we found were pharmacological support and adding objects to the environment. So things such as the provision of free vapes, NRT and so on, and any other leaflets and service user resources were identified. Restructuring the physical environment was a key one in terms of that appointment flexibility and the flexibility in the resources that were provided, and social support as well, which again is key in the enhanced support, having that enhanced behavioural support from the smoking advisor. In terms of service providers, the key behaviour change techniques that we found were relating to restructuring the social and physical environment, such as the referral pathways, the enhanced referral pathway. Other BCTs or behaviour change techniques, were related to things like action planning and problem solving, making mobilisation plans and so on, and then social support as well. So, organising team meetings and steering groups and so on to kind of facilitate implementation of the service. So those were the findings from the documentary analysis. The third work project that we did was to look at the experiences of service users and service providers. And this third work project was actually split into 2 parts. So the first part, which I'll discuss now, was an online survey that we did with service providers. And essentially, this survey was sent to all providers within the service, whether that be deliverers, managers, referrers, or strategic overseers. And we had 20 service providers take part. And what we assessed in this survey were essentially 3 things. So one of them was the Cumbria model, which some of you might have heard of, but it's essentially assessing whether service providers have the perceived capability, opportunity, and motivation to implement or deliver the service. And you can see the items that we specifically assessed in the top right of the screen there in the table. We also looked at different measures of acceptability using the TFA, which is the Theoretical Framework for Acceptability Scale. And we looked at things like how ethical is the service, how acceptable do you perceive the service to be, how comfortable are you in delivering it. And then we also looked at intentions as well. So how much service providers intended to engage in opportunities to deliver or implement the service, and how much they would intend to seek opportunities. So essentially all of these variables that you can see on the right hand side of the screen were assessed on a 5-point scale, where service providers essentially rated 5 for strongly agree for that, or 1 for strongly disagree. And what we found was that the majority of service providers, or the general average, was that there was good perceptions around the acceptability of the service, and there were positive perceptions around perceived capability, opportunity, and motivation, which you can see by most people scoring 4 or more. The only kind of measure that maybe there were more mixed views on was the perceived burden to deliver or implement the intervention, which is essentially the perceived effort to deliver the intervention. There were more mixed views around that, with people kind of rating strongly agree to strongly disagree, kind of in the middle there. So those were the findings from the online survey. But the second part that we did for exploring perceptions and experiences of service providers and service users was through semi-structured interviews. So for this, we recruited 18 participants. This included 4 service users, which were only from pilot sites B and C. It was difficult to recruit service users. We know it's a difficult group to target, but we managed to get 4, which we thought was great. And then we had 14 service providers who were from all of the 4 pilot sites, and including all different levels in terms of the roles. So we had deliverers who actually delivered the intervention to service users, implementers, commissioners and strategic overseers, managers, and we managed to have 1 referrer, a GP as well. In terms of the procedure, all service providers took part in interviews over Teams, and then we offered a very flexible approach with service users, where they could either take part in an online survey, a phone call, or a video call, and all of them went for the phone call in the end. The way in which we analysed the interviews is that we coded for barriers and facilitators relating to implementation of the service, and also delivery and participation of the service. And we've split the coding for those 2 in terms of, we've identified barriers and facilitators specifically for implementation and also for delivery and participation. And that'll make more sense on the next slide. We also coded these barriers and facilitators within frameworks using the theoretical domains framework, but the one that we're going to mostly focus on is the Cumbria again, barriers and facilitators relating to capability, opportunity, and motivation. So in terms of factors that we found relating to service implementation, we identified a range of barriers and facilitators and mixed, and we can see we identified mostly facilitators, some mixed barriers and facilitators, and then a few barriers. And just to kind of highlight on the left there, you can see the Cumbria domains, and we can see from motivation, we can see that's primarily facilitator. There are mixed barriers and facilitators regarding capability, and the same for opportunity. So I'll talk about these in a little bit more detail, starting with the barriers. So in terms of the barriers, there were some concerns around data recording and monitoring. So for example, at the start of the service, there were maybe some unclear expectations about what data needed to be recorded and monitored in terms of, recruitment and outcomes and so on. And also the data monitoring systems between sites differed. So liaising between service sites and then the NHS and so on was quite difficult as a barrier. So that's potentially something to work on as a recommendation. The second barrier is around evidence of service impact. So although there was a lot of support around the enhanced service, there were some perceptions that potentially an abrupt quit would be preferred for some service providers, so that evidence around the positive impact and the success of the cut down to quit approach would be beneficial for service deliverers to kind of make them feel capable to deliver the service. And the final barrier, and I think this is maybe one of the key ones that we found was quite big, was around links with primary care. So we found that there were generally some difficulties engaging with GPs in the referral process, you know, whether that be due to staff capacity, having different or more important priorities at the time. Generally, the links with primary care was perceived as a key barrier and something that needs further development to implement the service. But moving on to facilitators, so things that worked really well. So we found that social support was a key facilitator for service providers, good teamwork between staff, you know, going to colleagues for support when needed, and having good management as well. So that social support element was that was perceived as a key facilitator. And like I said previously, motivation was a huge facilitator for delivering the service for service providers. So one of the things that helped was service user feedback and quick successes. So service deliverers and implementers and managers said that hearing either formally or informally from service users about the positive impact the service had was a key motivator for delivering the service and continuing to deliver the service. And also quick successes was also a facilitator. Service provider motivation was also a facilitator. We found from the interviews that all service providers and deliverers were very motivated to deliver the service. There was an understanding around why it's needed, and there was kind of a passion and a drive for it. So that motivation was there, and that was something that was a key facilitator for implementation as well. And this kind of led into the perceived impact of the service as well. So the general perceptions around the service was that it was positive and it was having a positive impact, and this further motivated staff to implement the service. And again, leading into the final facilitator, those positive perceptions have led to service providers kind of saying that they would like the service to be expanded, but maybe across different services, or maybe wider than the specific SMI definition. So there were some thoughts around it would potentially benefit people who strictly don't fit the SMI definition in terms of bipolar schizophrenia and psychosis. Potentially, you know, other people who have other severe mental health difficulties may benefit from this service. So that was a perception amongst staff. And finally, in terms of mixed barriers and facilitators, in terms of training and skills development, there were perceptions that the training was good and that it provided a very basic understanding around, you know, the service and the referral process and, you know, why the service is needed. But there was a greater need and kind of a request for training to include information around other mental health difficulties outside of the strict SMI definition, because often, you know, people have other mental health difficulties alongside their severe mental illness, and also this disability training would have been beneficial as well. And the final one was also around e-cigarettes. So although there was training on e-cigarettes and that was beneficial, there are mixed perceptions around the potential risks related to e-cigarettes. So some training and understanding around that, about why it's potentially more beneficial in comparison to smoking, would be useful for staff. Also, the next mixed barrier facilitator was around outreach and identifying and accessing different SMI patients. And this kind of links to the links with primary care barrier, but to identify as many individuals with SMI as possible and really go for that no wrong door approach. Some services were quite successful in this, and it often depended on the services that were available to them to kind of identify individuals with a SMI to deliver the service. However, where sites maybe didn't have those services available, there were more barriers in place. There were also difficulties in terms of identifying patients with SMI due to data access, permissions and restrictions. So that's a potential barrier for reaching this particular group as well. Funding was a mixed barrier facilitator. I think it was mostly perceived as a facilitator in terms of the funding was perceived as sufficient. and there was kind of that freedom around what to do with it, to use within the service. But there was some uncertainty with service deliveries around whether the funding was going to be continued once the service had finished at the end of the year. So just some clarity around the continuation of funding and where they stand would have been beneficial. And finally, in terms of a mixed barrier facilitator for service implementation, was staffing resources and communication systems. So one thing that was mentioned was that there were champions at kind of a commissioner level, and that was really useful, but it would have been beneficial to have champions kind of at a primary care level, at a deliverer level, to kind of help facilitate implementation and delivery, and also to improve communication systems. So there were comments around absences and sickness, and comments around communication systems needing to be in place so that if someone is off sick or there are new members of staff coming in, those systems are in place to continue the service in a smooth and efficient manner. So those were the factors relating service implementation. And finally, we've got factors relating to service delivery and participation. So this is more relating to the direct delivery of the service to service users. And as you can see, we mainly identified facilitators, which is great, and a few some mixed barriers and facilitators as well. So I'll start with the facilitators. One of the key facilitators that was conveyed by service providers was that understanding of the wider social determinants of the SMI population and the need for the service. So service deliverers really understood why the service was needed. They put in that effort to really understand the circumstances of service users and adapt and tailor the service for them. And that was something that was really picked up on by service users, who said that there was that understanding from service deliverers, and being understood and having it adapted around them was really helpful. So I've kind of talked about the second facilitator there, but they kind of complement each other in terms of that understanding and adapting to service user needs. In terms of opportunity as a facilitator, so stop smoking advisor support kind of fits in with the previous facilitators I've mentioned, but a really key thing that service users said helped them was the stop smoking advisor support. There were comments that, although they received various other resources to help them, one of the key things was the support from the stop smoking advisor. And just to kind of note as well as I'm discussing this, the service users we did have in our research, all of them had either completely stopped smoking or had cut down after a long period of smoking throughout their life. So, these findings might be a little bit biased in some way, that we got people who have quit, but when they said they had quit or cut down, the stop smoking advisor support was one of the key things. In terms of motivations facilitators, so the consequences of quitting or reducing smoking was a key facilitator for service users, whether that be, this is a facilitator for them actually engaging in the service to begin with. So knowing that a consequence of stopping would improve their physical health. A lot of them had a physical health scare. It would improve their finances. And then as they took part in the service and reduced their smoking, these consequences started to come into effect and they noticed it. So that was a continued motivator for them engaging with the service. Generally, the perceived impact of the service by service users was positive, and that kind of leads on from the consequences of quitting or reducing smoking. And then the final facilitator is around goal setting with service users. So service deliverers, kind of linking to the adapting theme, they adapted their approach with goal setting with service users to kind of suit their needs and help them aim towards something between appointments. So whether that be changing their schedule and picking up a cigarette at a different time of day or putting a pack of cigarettes away from them, then service providers really worked with service users to come up with these individual goals. And another key goal setting theme that came up was CO monitoring was found to be really effective. Service users really said that kind of working towards having a non-smoker reading on the CO monitor was a really big motivator for them to continue to reduce smoking or quit smoking between the weekly appointments. So yeah, mostly facilitators for delivering participation, but there were some mixed barriers and facilitators. So in terms of opportunity, to deliver the intervention, flexibility was mixed. It was mostly facilitator in terms of appointment flexibility, particularly for service users. They really like the flexibility with home appointments or phone appointments, or, you know, anything in a way that suits them, and also having the flexibility and resources in terms of vapes, leaflets, easy to understand resources that's not, you know, as someone said, doesn't require a doctorate degree to understand. But service providers said there's some barriers around the flexibility of the service. For example, services that are provided in more rural areas, or maybe have limited staff capacity, don't have that maybe scope for flexibility to go out into service user homes and to deliver that intervention, despite it being one of the key things that service users said was helpful. So some kind of environmental opportunity barriers there around appointment flexibility. The second one is around external social support, and this is purely for service users. Some service users said that external social support outside of the service was great. They had support from the community, and support from the vaping providers as well was said to be really positive. But there were some service users that said that family circumstances, difficulties with friends or other relationships was a potential barrier for them kind of engaging with the service and continuing to reduce or quit smoking. In terms of motivation, changes in service users' perceived capability was, again, primarily a facilitator. So service users initially started the service and said that they were either a little bit skeptical or they just wanted to try it to see if it worked, but, you know, weren't expecting anything, but said they were pleasantly surprised by how much of a positive impact it had, and that they'd actually managed to reduce or quit smoking. But potentially barriers around the perceived capability relate to mental health barriers. So service users said that if they were to slip up or relapse, it would likely be due to the fluctuations in mental health. But despite that, there was still kind of a motivation to continue quitting, and the perception of their own capability was better than before they started the service. And then the final theme for delivering participation relates to service user motivation. So, like I said previously, all of the service users that we had in our interviews either completely cut down or completely quit smoking. And all of them said that they had some level of motivation to quit, whether that be due to health or finances and so on. And that was a key facilitator, but service deliverers said that that's not the case with all service users. You know, service users need to have some element of motivation or wanting to quit to actively participate in the service and to try and quit down. So the fact that we didn't get service users that maybe didn't quit smoking or struggle to engage with the service might be something we're missing there in terms of service user motivation. Just to kind of provide a little bit of a visual as to how we apply the COMBI model. I've just created this diagram or this visual. So what we can see on the left here is all of the different themes that we've identified. We can see that these feed into either capability, motivation, or opportunity to implement the service. And these are kind of the things that, if focused on, would help to facilitate service implementation. And then the same applies here in terms of service delivery and participation. And we can see that the majority around this work relates to motivation, as a facilitator. Okay, thank you. And I'm just going to pass over to Angela now, who is going to talk about the recommendations that we've provided based on our findings.
Thank you, Lauren. So from the findings that Lauren just summarized, we created some recommendations, and the recommendations were sort of revised in two rounds. So the first one was from the findings. We drafted some ideas that we presented to 11 stakeholders, and then from that feedback, we revised the recommendations, and then in the second round, shared with 30 stakeholders and got further feedback on the recommendations. But overall, we got. Oh, sorry, Lauren, would you mind taking us to the next slide? Overall, we got support for most of the recommendations, with 3 being less or more uncertain in terms of either because they required extra support or they required resources that were external to the service. And that's the improved data management systems and evidence gathering early in implementation. And this recommendation really links to, for instance, the NHS England and having an initial pilot of how the data is going to be gathered and stored. And so that is one of the reasons why potentially this recommendation is seen as less likely, because obviously it would involve others to put it in practice. The next one is to maintain and expand the flexibility in the service delivery. And this one is related to having the staff available in order to provide that flexibility. So again, something that it relies on funding and on staff availability. But certainly all the recommendations were seen as important. It's just how to put them in practice will depend on others. And finally, enhance preparation and support for sustained motivation post-service. Again, this is thinking about once the service user has gone through the service, what other resources are out there, what other services do, for instance, help with relapse prevention. But obviously this will imply extra resources that are currently there to support the service, but clearly something really important to consider in future implementation. Next slide, please. Oh, sorry. Actually, can we just go back just to go through the other ones that were also viewed as highly likely to be implemented. So the first one is strengthening primary care engagement and referral pathways. So this was really welcomed by all stakeholders that provide us feedback on the recommendations. An example of this recommendation would be assign local champions within primary care, offer flexible and accessible training, for instance, on MEC, but also on very brief advice for smoking cessation, and simplify the referral process. But this would imply working closely with primary care. Second one is enhanced training and skills. So this is the specific training and skills that was highlighted in our findings. So this could be on mental health conditions that go beyond the SMI, and to help staff understand what the context of some of the service users, some more guidance in terms of e-cigarettes and vaping, and training opportunities post-implementation. So the third one is the data management systems that I already mentioned. Fourth is the flexibility of the service delivery. And then the next one is prioritize tailored support. So this was something really welcomed by the service users, and something that it's really important for future implementation. So strengthening focus on interpersonal skills and training for stop smoking advisors, and formalize consistent goal setting approach to work with service users on this, because we could see from the deliverers and also from the service users that they really like this approach, but also seeing the positive impact of that. And then the next one is enhanced preparation and support for the sustained motivation. So that's the maintenance of the service once we move beyond the initial stage. And finally, use evidence to strengthen the cut down to quit model. So this is related to research evidence and collate and disseminate as much as possible this evidence to support the approach and the enhanced service for smoking cessation. And this is all we had to present. Thank you so much for your attention, and I think there is time for some questions now. Over to you, Rachel. Thank you again.
Thank you so much, Lauren and Angela, for that brilliant presentation. So much there in terms of what is currently happening or what has happened in the last year and a half or so, but also lots of important lessons and opportunities for us to adapt and adopt these practices. So thank you very much for that summary. Just to make everyone aware that following this webinar, we will share the recording. We will also share the full report, Angela and Lauren's slides, as well as a lay summary, which has been kindly prepared by the team there. So if people don't want to go into the details, there's something that summarizes this research and makes it easy for anyone to consume. While people are probably trying to formulate their thoughts and ideas and questions, please, because you've got an open audience here for Angela and Lauren and Katie, if she wants to jump in as well, to ask any questions. Jojo, please, would you maybe perhaps help us with the unmuting people if possible? We'll see how we get on with that technology. But in the meantime, I've got two questions just to get the ball rolling. The first question to the team was around, could you share with us what challenges you encountered while trying to do this research? And then the second one was something Lauren had mentioned around the perceived burden or effort that was indicated by some of the people that took part in the evaluation to deliver the intervention. It'll be great to see if you could expand on that. What does that mean? Because obviously we don't want people to leave today thinking, oh, it's too hard to do, but we want people to understand, obviously it's not easy, but it's an important thing to do because there obviously benefits to the population. Thank you.
Thank you, Rachel. I think I can probably start and then hand over to Lauren, if that's okay. So the first one and related to the challenges, I would say recruitment was the most difficult aspect of the research. So recruiting for the interviews, both service providers and also service users. We expected service users recruitment to be more challenging just by the nature of recruiting service users overall. But it was actually really difficult to engage with some sites as well and get them, even though there were, service level agreements in place and all of that was external to us, we still found it quite difficult sometimes to get answers from sites, mainly because we wanted really the message to be as accurate as possible. So we wanted to get their feedback, but in most scenarios we did eventually get their level of feedback, which was really good. And probably Lauren will have some other things to add to this, or to the burden question that relates to the survey.
Yeah, I mean, I obviously second that in terms of the recruitment being probably the biggest challenge. In terms of trying to engage service providers. We wanted to have service providers from every site, so that's what we were aiming for, and it was quite difficult to achieve that, but we did in the end. And then obviously reaching service users was difficult. I think there were efforts from service providers to engage service users to facilitate that process, but it was just a difficult group to reach. And I think the service users we did get kind of came from two providers who were quite, engaged with their service users in the service. So that's definitely the key barrier. I think in terms of the burden and the effort finding that we found in the survey, it's difficult to make assumptions about it because in the survey we only, it was only included as a scale, like a ticky box scale, and we didn't get qualitative data on it. But if we interpret that in line with the interviews and can maybe draw some ideas from that, it would probably be around, you know, the service providers said that there is like an extra level of effort to kind of, you've obviously got more appointments with service users, there's more follow-ups with service users, and there is an extra level of effort in terms of being adaptable and being flexible and having those skills to adapt to each and every person. And I think service deliverers tended to say that they enjoyed it and it's what they liked, but I think there is that extra level of effort at deliverer level to kind of meet those service user needs who have SMI. So that's just an interpretation based on the interviews, but yeah, we're not entirely sure why there were mixed views around effort. Yeah, I hope that answers your question.
Yeah, it does. I thought it was useful to just give people a flavor in terms of that, in case people have questions. But obviously, if people have any specific questions around the research, would it be okay for them to contact you about that? Would that be acceptable to the team? Fab. I've got two questions in the slides, or not in the slides, in the chat. I'll start with the first one because that's perhaps a bit more straightforward, and I think the team might be able to answer that, which was around whether health literacy was considered during the recruitment. I assume this is from Diane Walker. I assume this is recruitment of participants towards the evaluation. So
yeah, I'm happy to answer that one. So the way we so the process to engage with service users was via the providers. So we had a similar approach before in with the service users with severe mental illness that worked. So we thought this would be a really good strategy to implement. So we ask any providers or deliverers, advisors to check whether they could share some of the materials, but the materials were very much lay summary, and we also wrote smaller blurbs, and the providers could share with the service users. So we hope that by using that connection, that would really help, instead of having all the materials that we had initially from the research team sent to service users, because that would have felt a bit kind of a cold approach. So I guess in a way, so it's a roundabout way of answering the question, and that we try to not overload service users with specific materials, and instead go with the service providers to help identify service users or share within their networks of service users to then reach out to people that consent to their details being shared. I hope that answers the question.
Well, I hope it answers the question for you, Diane. Yeah, it's very tricky. And I think from what the team have described and what I know, it's been quite a challenging area or group to research for multiple reasons, complex and chaotic life. So, it's great that we've been able to get some insight and some information, which obviously will help to inform practice. So I'll go back to the very first question. Sorry.
Can I just add something that I completely forgot, which was all the materials that we develop. We first took them to our experts by experience. So we had a specific panel made of people living with SMI that help us design the materials. So that also helped to get the message right, and completely forgot to mention that. But also the lay summary that everyone will get access to was also, we've done the same. So we went back to that panel to check wording, but also have some interpretation of the findings, and they all said that our key findings resonate with their experiences, which was really positive. Sorry, Rachel.
Oh no, that's really, really important. It's two parts, isn't it? First of all, getting people with the lived experience to be able to kind of check that the context and the questions you were asking were relatable, but also making sure that everyone understands. And if you've not got research background, sometimes the terminologies can be quite complex. So I think that's great that you had that approach in engaging with multiple people at various points. Gillian, I assume it's Jill, I know from Middlesbrough, might be another Jill, has asked the question, which is very service specific, but I think it's still worth mentioning here. And it is really more around how do services manage the client's health when they quit. So for instance, in their own service, the Stop Smoking service had difficulty, especially with the blood level monitoring when they take a medication called quetiapine, and they found it near impossible to engage with mental health services. I think, first of all, directed to the researchers, did that come up in the conversation at all around some of the barriers or concerns around engaging with external services where there was perhaps shared care? Either Angela or Lauren.
Yeah, I think this came up in terms of where. Sorry, I'm not sure what the blood level monitoring, are they two separate points?
Well, it's one point. It's essentially around the support for people who are taking other medications, so psychotropic medication for their mental health, where their dosage maybe needs to be adjusted. So I don't know if it came up in any of the conversations you had.
I think not as a barrier. There was definitely service deliverers who said that there was training around medications for mental health and how that might come up in the service and how to manage that. And they said that was really been beneficial in the training. But I don't think
not specifically around that point. No, that's absolutely fine. And I think probably also it might be useful if any other people have access to the chat. So Brenda from Northumberland and maybe the service in Durham and South Tyneside, if you don't mind just putting in how you manage that. I think this also maybe points to something around us doing a bit more work and engaging with any other community mental health providers. So clearly there's something there that perhaps could have been improved, but that's an opportunity for us to do some more collaboration, I would say. So if Brenda or anyone from any of the services in Durham or South Tyneside is there and can maybe respond to Jill to see how they've managed that. And if not, maybe it's an action for us to take outside this to see how we provide that support to the system, so that indeed the conversations and the engagement with our mental health services can work. Fab. And I don't know if we've managed to unmute people, but before I go on, I don't know if Leslie can speak. I think your mics are still unmuted. Leslie, can you speak?
Hi, can you hear
Oh,
me?
hiya, grand. Hi,
Yeah.
Leslie.
No,
Thank
it's
you.
just in response to Jill. Quetiapine isn't actually affected by smoking cessation, so it's clozapine, olanzapine, haloperidol. There's other medications affected. I think Jill's from the Middlesbrough area. We've been trying to link to try and get a pathway to support patients who go into the community service and support from mental health. I met with the trust-wide GP advisor, James, on Monday with our senior medical director, and we're actually looking at a brand new pathway to actually work out how on earth we have a service whereby patients aren't passed from pillar to post. And I think that's what's happening. They go to the Middlesbrough service or Darlington service. They have to go and see a mental health nurse if any of the medicines are affected, so a nurse prescriber or a consultant. So somehow we need to look at how we develop this. So like I said, we had our first meeting with James, trust-wide GP advisor, who's based in Bishop. And we're now looking at future meetings. We're going to link with our trusted pharmacy chief pharmacist. We're going to link with GP practices in the area. We're going to do a whole review of how many patients are actually on their caseload, because a lot of patients on olanzapine are no longer under the care of mental health services. They are under the care of the GP. But once they stop smoking and have to have plasma level testing, they then have to somehow be under the care of the Mental Health Trust again. So we have started the work. We've been doing it for a few weeks. The first meeting took place on Monday. So I think it's watch this space. But we know there's a significant number of patients with an SMI diagnosis who unfortunately cannot get this pathway of support. So I think just to Gillian to say, bear with us. We're trying to work on it. We've been contacted by North Tees and Hartlepool, Darlington, North Yorkshire. So we're working with everywhere to see what we can now put in place. We've got Seamless in York. We've got really good in one of the community services in Middlesbrough. We are looking potentially, if funding ever came along, we will set up SMI clinics specifically for any patient come through straight to us. So just to say, watch this space and fingers crossed.
Thank you so much, Leslie. And I can see Gillian has asked if she and Julie can be added onto those meetings. So maybe something to take outside this, but thank you very much for your input. That's really useful. We're learning all the time, aren't we? Because I was thinking personally, I didn't know what that medication was. So I'm pleased to know that, yeah, I think I still knew that. Got two more questions. Well, one is a question and two comments. One is from Urena, who's asking about any specific training or refresher sessions that offered to participants, advisors, practitioners prior to or post recruitment, or was it an exclusion criteria? So I'm thinking this is relating more to the research as opposed to the delivery. So I don't know if either of you would like to attempt that question.
I think in terms of training, there was some training in place, but I think we have this has triggered another conversation, Rachel, right, about future training and adding to the training. So there's definitely scope to add resources that people can get on and access if they need it. Lauren, do you know if any site already had some refresher training happening? Can you recall from the top of your head?
I can't recall from the top. I mean, the training that was mostly discussed was around kind of the initial NCSCT training and the tobacco dependency training. So it might have been mentioned, but off the top of my head, I can't think of anything.
Sounds like I think it's certainly something that we've already highlighted to have a conversation around this.
Yeah, so it sounds like there was more of the training for the people actually delivering the service than people who might have been involved with the research, is what I'm getting. But again, I think training is always good because as long as it's got a purpose, which in this case it does. There was a comment from Rachel who's joined about valuing more work on this because of the inconsistencies across Durham for us. So obviously Durham was one of the pilot sites, but this has not been across the board, and I think it's going to be adopted. So again, definitely this is an opportunity for us to share, to learn, to grow. So yeah, and then there was a second comment supporting what Rachel said around how this pilot helped to focus around the elements of COM-B for services, but then we need to be thinking more around parts of the system around the local authority stop smoking service and what happens. And I think it's just a clarion call around making sure that the offer that is available for smokers with SMA, whether they're in primary care, whether they are coming to a local authority stop smoking service or an acute community mental health, is flexible enough. I just going to check if there's any more comments. Oh yeah, so it's just a comment there. I'll let people continue to converse in the chat. So I want to end by firstly saying thank you very much to the team from Northumbria University, Lauren, Angela, and Katie, who's on the call, silent partner, but in terms of helping us with this research on behalf of the task force. I want to thank everybody who's taken time out to attend and listen in. I think it's been great because we've learned so much about some of the challenges, but also the importance of this area of work and why we need to continue to support adults, whether they have SMI or whether they've got mental illness. And we've learned a lot about the fact that flexible, tailored and adapted support is really, really important. It's been really interesting to learn about the fact that, you know, it's not a single issue. So people who have got SMI might be presenting in an acute setting. They might be pregnant. They might be presenting in a community setting. They might have additional comorbidities. And so there's that cross section, and there are the interdependencies that we need to be thinking about. And great to hear some examples of how lives have been changed as a result of that, and some of the tools that have been utilized, like CO monitoring, pharmacotherapy. And I guess the other thing is around that opportunity that we have to work closely together. So it's great to see, you know, Leslie and Jill from Middlesbrough and Tuve and Kerry and Rachel talking about that collaboration and parts of the system just coming together. We need to be doing a bit more in primary care. We need to be working more with our voluntary sector in community. So I guess I'll just leave everyone with that challenge around, yes, we've learned about what's working and what can work, and it's more around, can we go and implement it? We know what the barriers are, but we also know what the facilitators are. We've got the tools in our box. So let's just go ahead and just implement it. So thank you, everyone. We will send you as much materials as we have following this webinar, but thank you, everyone, and take care. Enjoy the rest of your afternoon. Bye now.